Okay, so we might get started with care plans and MBS items, frequently asked questions, and common mistakes. My name is Magali De Castro. I'm a registered nurse. I'm the founder of practicenursing.info, and a lot of you actually know me or have heard me speak or have done practice visits or have worked with me. So to those of you, hello again. Those of you who haven't heard me before or met me before, I want to thank you for joining us, and hopefully I can provide a fair bit of value and some insights and answer any questions that you may have on care plans and related items. So what are we going to look at with this seminar, or tele-seminar as I like to call them? Today we're going to have a quick overview of GP management plans, GPMPs for short, team care arrangements, or TCA as they're often known, and the related MBS item numbers. We're also going to have a look at the different types of plans, so what they look like. We will also have a chat about collaborating with other providers, for example, allied health, which is often one of the reasons that care plans are put in place to provide patients access to allied health. So we'll talk a bit more about that later. And we'll address some of the frequently asked questions. I've actually already received several questions that I can work through, but make sure that if you have any questions, you can either raise your hand by clicking on the little hand icon on the left of your GoToWebinar control panel. I may only address these questions by unmuting you towards the end, but in the meantime, you can also use the questions tab and just type it in, and I can have a read of them as we go. All right, so let's get started. First of all, before we even get into GP management plans and team care arrangements, I quickly just want to have a word about the purpose of the chronic disease management items, as they're now called. These items used to be formally known as EPC, extended primary care. We no longer use that term. Now it's chronic disease management, or we try and refer to them as GPMPs and TCAs. The real purpose of this, and Medicare's, well, my view on Medicare's purpose behind these items is to try and shift some of the care that we're providing, to try and look at planning or having a planned approach to chronic disease management in general practice. Now, it's been quite controversial because a lot of GPs have, when the items were first introduced, they were saying, look, it's a lot of paperwork, why all this red tape, we're doing all this, we're providing all this care. And in some instances, that's true, a lot of the care is being provided, but by and large, in a lot of areas, it actually isn't. And the introduction of the GP management plans and the team care arrangements, and partly having that criteria for documentation, has meant that a lot of things like, to give you an example with diabetics, HbA1cs are done on a more regular basis, microalbuminuria, a lot of the tests and best practice guidelines are adhered to much better, because we have essentially we have checklists, or we have a way of keeping track of it. Now, the real purpose of this is to try and improve the way we manage chronic disease in the community to prevent hospital admissions and complications of people who have chronic conditions. However, as we'll discuss in a little bit, it's not so not exactly how it's played out. A lot of us will have come into contact with GP management plans and team care arrangements because a lot of patients are coming in and requesting that this piece of paper be put in place so that they can access their subsidized allied health services. So they can access their podiatrist or their physio, because either their physio has told them that they can get these sessions for free if they get this piece of paper put in place, or because their neighbor or their sister or brother has gone through that process and now they're getting their sessions for free or subsidized. As we know, this has brought up a lot of issues because not everybody's eligible, and that's what we're going to talk about. And also because access to allied health is a bonus, but it shouldn't really be the reason for a plan to be put in place. So let's have a look at what these items are, and hopefully we'll shed a bit of light. The main item is what's called a GP management plan, or GPMP for short. And this is what's item 721. And this is the original or the main document that we would be putting in place. This, we need the eligibility criteria is we need a patient who has a chronic condition. Now, a chronic condition, according to Medicare, or as defined by Medicare, is one that will last 6 months or more, or it's a terminal condition. Okay? Now, that's quite gray in a way, because there's questions of, obviously, we have things like diabetes, asthma, and arthritis, which are chronic conditions. But then we have things like high blood pressure, high cholesterol, even things like obesity, and a lot of providers say, look, this will last more than 6 months. But in Medicare's view, these things are actually not chronic conditions in and of themselves. They're considered risk factors towards developing a chronic condition. So again, things like high blood pressure, high cholesterol, and even obesity by themselves are not considered chronic illnesses. So by themselves, they don't really make a patient eligible to have a GP management plan. However, there is a proviso. Medicare does give this proviso or this flexibility to GPs, where if the GP considers in their clinical judgment that this patient is quite complex for whatever reason, and they're requiring they would really benefit from a comprehensive general practice GP management plan, and they believe, so the GP believes that a board of their peers would agree that in this instance, even though there isn't a clear-cut chronic condition, even though there's only something like, for example, high blood pressure or overweight, that the circumstances are such that a GP management plan is warranted, then that's allowed. But again, that's left to the individual clinical judgment of the GP. By and large, we only really, the clear-cut conditions would be things like diabetes or asthma or arthritis. Now, this GP management plan, which is our original document, needs to have essentially just a couple of key things. One is we need to identify what the chronic condition is that's making this patient eligible. It needs to identify what are the problems. Yeah, what are the problems or needs that are coming up as a consequence of having this chronic condition, or just in general, what are the problems and needs that this patient has? Then we also need to identify, once we've had the problems and needs, what are the goals? What goals do we want to achieve for those problems and needs? Then we need to identify the patient actions. So what's the patient going to do about it? Yeah. And then what are we going to do about it, which is what we call the treatment. And then we need to identify a date when we're going to review this plan or review the progress towards these goals that we've set out. Now, ideally, not ideally, the problems and the goals, and the patient actions should really be developed in collaboration with the patient. So this is a conversation that we're having with our patient, where they're identifying in their words what do they feel is the main problem, what would they perceive as a good goal or outcome for those, and also what do they feel would be the role that they can play, well, their patient actions, to make sure that we achieve those goals. What often happens is that the document is set out, or these problems, goals, and actions are set out in a template in advance before the patient even walks through the door, and they tend to be very heavily based on biomedical factors. So, for example, blood pressure and weight and their cholesterol and things like that. When really it's much more beneficial to have a holistic view of this patient's health. Yeah, so that's including things like if they perceive that actually something like access to public transport to get to appointments is a bigger issue, or they might say in their words that what they want is to be able to play with their kids again, yeah, or to play with their grandkids. because they keep getting puffed and feeling out of breath too quickly. Those are things that we can actually identify in the plan, and that's going to be much more likely. It's an approach that's much more likely to achieve a patient who's engaged. So let's keep going with this. So essentially, this main document should identify chronic conditions, what are the problems and needs, the goals for those problems and needs, patient actions, treatment, and when are we going to review it. That's it in terms of requirements. A lot of the templates out there have a lot of additional information, which is good, and it may or may not apply to your patient, but all of that is additional. In terms of Medicare requirements, these are the essential elements that need to be part of the plan. Now, this document can be reviewed it should really be reviewed every 6 months. The minimum review period is usually 3 months, but really it should only be reviewed 3 monthly for patients who are quite complex, so your frequent flyers, the patients that are coming in on a regular basis. Most patients who have a chronic illness should be reviewed every 6 months. Now, the item number that we would use for a review is 732, and that's the same item that we use for GP management plans and team care arrangements, but we'll talk about that in a little bit. Just as an interesting point, if we put a GP management plan in place, this item 721, which we can do by itself as long as we meet this criteria, and we're documenting those things, it doesn't actually give the patient access to any allied health or any rebatable items for any other services. In order for us to give our patients access to these services, we need to put in place what's called a team care arrangement, or TCA for short. For a patient to qualify for this, they need to be complex, the condition needs to be complex, and they must require what's called a multidisciplinary team, or at least 2 other providers outside or in addition to the GP. Okay? So this is what we call a team care arrangement. We need to, so these 2 providers outside of the GP need to be providing different services. So it can't be, for example, 2 physiotherapists. It must be a physio and say a podiatrist, for example, or a dietitian and a diabetes educator, or something like that. They need to be providing different services, and you can't really include another GP unless that other GP is providing a service that's not general practice related. For example, there's GPs that do acupuncture, in which case that's fine, you can include them if that's the reason. Now, the type of providers that can be included must have at least 1 allied health professional, for example, exercise physiologists, podiatrists, optometrists, dietitians, diabetes or asthma educators, and it may include specialists. I will show you a comprehensive list a bit later on that has a lot more detail, much more details than of what providers can be included. Again, the review should be every 6 months, with the minimum claiming period being 3 months. And the item number, as we've mentioned briefly before, is again 732. You can claim this item twice on the same day. So if you've done a review of the GP management plan and a review of the team care arrangement on the same day, you can claim 732 and 732. Just make sure, because it's the same item twice, what often happens is Medicare will reject one of them, thinking it's a duplicate item. So they must go annotated, one saying that it's a GP management plan review and the other one saying that it's a team care arrangement review. Oftentimes you might have to put a different time signature on it, and what ends up happening is as soon as you annotate an item, if it goes with a separate note, it actually goes through human eye to Medicare as opposed to just being processed by a computer, which will just look at, oh, it's the same item twice and reject one. It must have been a mistake. Yeah. So that can be done. Now, the other thing that a lot of people don't realize is it's not just a matter of picking 2 providers, putting them in the form, and claiming the item. You actually need to gain consent from these 2 providers to participate in the care of this particular patient. Yeah? What do I mean by that? They need to, 1, agree to participate, and they should provide you some input as to what their role is going to be. Something like, well, they're going to be the dietitian is not really enough. And this doesn't have to be an extensive or complicated thing. It can be something as simple as, okay, I'm sending this patient to a dietitian. Is the dietitian's role going to be around diet education for diabetic diet, or low glycemic index education, or low GI diet, or because it's a newly diagnosed diabetic, for example, or is the purpose of the patient seeing the dietitian for maybe weight loss? So it's looking at diet to help with weight management. So giving it a specific, we need a specific input or a specific direction of what the treatment will be. I'll talk a bit more about this in a moment. Now, we can do a brand new plan, so a brand new 721 and 723 every 2 years. That's the recommended interval, should be every 2 years or 24 months. Minimum claiming period is every 1 year or 12 months, but really what's recommended is that when a GP management plan and team care arrangement are put in place, it should be reviewed every 6 months up until the moment where a new plan needs to be put in place, which should really be 2 years. But if at the 2 year mark the patient's still fairly stable, or there's not a lot of changes that need to be made to the plan, and it doesn't really warrant a new plan, then at those 2 years you could still just keep reviewing every 6 months. Here's an interesting little bit of insight into what's been happening with these item numbers. Now, the average GP will claim something like 130 something brand new plans, or brand new GP management plan and team care arrangement every year. That's a very rough average. In theory, because brand new plans should be done every 2 years, and reviews should happen every 6 months, you would expect that we should have, or the average GP should have twice the number of reviews in the year. Yeah, so it's 130 brand new plans. The actual number of reviews the average GP will do is around 30 something. Yeah, so they'll do about 30 something reviews and 130 new plans. What does this tell us? This tells us that the actual purpose of putting a management plan in place, which is the management component of looking after this patient's chronic condition, is at the review time. That's actually not happening. What this tells us is that plans are being put in place initially, which are triggering to 9 times out of 10 to allow patients access to allied health, which is fantastic. That's great, and it's providing services to patients. But then when it comes time to reviews, the reviews are not actually happening, or if they are happening, then practitioners aren't billing for them or billing correctly. The other thing is, at the time of review, you don't need to create a brand new document. At the time of review, we're going to review that original plan that we put in place. So what do? We would, if we've done it electronically, which, using our clinical software, what we can do is we can go and open our original plan. Yeah, so the 721 and 723 that we put in place 6 months ago. And then we will be looking at, okay, what's changed, what's new? Do we still have the same chronic condition? Are there any additional conditions that we would need to add here? Have they been diagnosed with anything new? Do we have any new problems, or are the problems still the same? How about the goals? Have we met some of these goals? Are we getting any closer? Were some of them a bit unrealistic, or are we still working towards them? Same with patient actions and treatments. And with treatment, I mean things like, for example, something very simple will be, we'll be checking their blood pressure every 6 months. We'll be checking their, doing a full blood check, cholesterol, and all of that every year. We'll be arranging referrals or coordinating services for them. That's examples of treatment. So what we'd be doing at the 6 month mark when we review it, we open that original plan, we have a look and modify whatever needs modifying. We are giving it a new date of review, which will be when? In 6 months time from today. And then we would save that document, and the majority of clinical softwares, when you're opening that document and saving it again, will prompt you, or will just automatically save it as a new letter. Yeah? So this new letter you can call GPMP and team care arrangement review. And that way you'll actually have your original plan, and now you'll have the review item. Okay. Now, when we have that 721 and 723, which, as I mentioned before, was formerly known as EPC. The only reason why I'm mentioning this is because a lot of allied health still refer to it using this term. So that way you know what they're talking about. But now we really talk about chronic disease management and GPMPs and TCAs. Having those two items is what gives patients access to the 5 allied health services in a calendar year. You can also get access to 5 nurse support and monitoring services, and you only really need, that's nurse item 10997. That's one of the last remaining nursing items that we have. And with that one, you only really need a GP management plan. They're completely separate services to the allied health, so you don't have to worry about if I use some of the nursing services, they won't be able to access their podiatry or things like that. That's not the case. They're completely separate, and they're really meant for nurses to touch base with patients on a regular basis, well, up to 5 times in a calendar year, to check on things, either to provide support or to check on, for example, how are they going with the medication management? Are they having any side effects? Are they going with the visits to the allied health? Yeah, so I usually refer to them as it's like a mini nurse consult. Always make sure, if you are using this item, that as a nurse, that you put an entry in the patient file, because if the practice is audited for having claimed these items, what they want to see is that on that date that item was claimed or billed, that there's a nurse entry saying what was the support or monitoring service that was provided. The other thing is that service, the focus of that session should be around an item or area that's mentioned in the patient's plan, yeah, either in their GP management plan or their team care arrangement. Another thing, the GP management plan and team care arrangement can be one document. You don't need to have 2 documents, and I'll show you an example of that in a little bit. I also want to talk about the 5 allied health services. Remember that this is 5 allied health services in total, not 5 per allied health. So that's 5 in total in a calendar year. What the calendar year means, it's from January 1st to the 31st of December. So for example, if a patient is put on a plan in November of 2012, they have up until the 31st of December of that year to use up their 5 sessions. Yeah? They might decide to allocate, well, we'll allocate 3 to the podiatrist and 2 to the dietitian. If they don't use all of their 5 sessions, whatever they don't use, they can't carry over to the following year, in the sense that the following year, by the following year I mean come January 1st of 2013, they won't be able to access 6 or 7 sessions. They'll still only get 5 sessions that Medicare will pay for. All right? Now, there's usually a lot of questions around this, and I will address these a little bit later. Let's keep moving. So what do some of these plans look like? And a lot of you will have been involved with care plans. So this is a fairly straightforward plan. This is in table format. So obviously this in your clinical software, a lot of this information would auto-populate as soon as you open it inside the patient's file. And here we have our key columns or our key areas, the needs and problems, what goals we want for those needs, patient actions, or what the role of the patient is going to be, arrangements and treatment, so this is what we're going to do, and progress. So I often use this column as a way to check, for example, if we have one of the needs is to make sure that their blood pressure is well under control. The goal is going to be keeping the blood pressure below 130 on 80. And their patient action would be to take their blood pressure medication or to adhere to the diet as agreed on or as instructed by their dietitian or discussed with their GP. And the treatment here might be to, well, we'll check their blood pressure every 6 months. Yeah? By progress, I would actually write down last checked, and I'll do this more, like usually with blood pressures, I tend to put them in here. But for example, if it was something like that or cholesterol, I'd say last checked May 2013. If it's something like cholesterol, I'll often say when it was last checked, so month and year, and then also mention if there was not necessarily write down all the values of all the you know, their cholesterol, triglycerides, HDL, LDL. I'll just document the values that are abnormal, and then I'll say all other values within normal range, because that just makes it easier. Now this document has the team care arrangement component underneath. Yeah. So with the team care arrangement component, we'd have the provider details. We'll list the providers, remembering that we need to have at least 2. And we can include specialists, but we need to have at least one of these 2 providers needs to be allied health, and then their role or input. Remembering that just putting dietitian is not enough. We actually have to specify what exactly is the dietitian going to be doing with this patient. And it doesn't have to be long and complicated. It can be one sentence, one line, but it has to be specific to this patient. This is another example of another type of plan, and this is just in dot point format. Yeah. There's no right or wrong way. As long as you have all the essential elements in the plan, you'd be good to go. Now, other care plans, just for a bit more variety, this is another one in table format that already has pre-populated a lot of the goals and some of the planned actions. And this is a relatively convoluted one. This is actually one that's available through the Royal College of Australian, the Royal Australian College of GPs. And the reason why it's quite convoluted is because this is intended as a prompt, so it's got a lot of the preventative interventions. And the idea is that you go through it and delete everything that doesn't apply. What happened initially was that a lot of GPs and providers in general were going to the template before reading what Medicare actually wanted or required as part of the plan. And of course, if you open this and you just see this is the template, it can be quite overwhelming. Remembering though that this is not what's required, this is sort of going above and beyond what's required. This is what's required. It's just these key areas and the dates of review. Obviously, we need to gain consent for this, and we also need to provide the patient with a copy of the plan, or at least offer them a copy. Okay, let's keep going. Now, those templates that I showed you, the simpler ones, the easier, the ones that are more streamlined, you can actually download from the practicenursing.info website under resources, care plans, and you'll see the list of, templates there, as well as I've put a couple of cheat sheets of sample interventions, patient actions, and needs and problems for specific chronic conditions. So there's one, actually, there's like a cheat sheet that I called it, that has the sort of 5 most common chronic conditions, and then you'd mix and match to tailor the plan to your patient. Now, there's actually a questions and answers document or page, which is from the Department of Health, and I've put the link there at the top. I'm recording this session, so you'll be able to access this session later on. I've got a link to this. The link to this is actually on the care plan page that I just told you about in practicenursing.info. And it's quite helpful because it clears up a lot of the questions and confusion around these items. Now, one of the things is, as I said, the communication between providers. This is one of the requirements. This is taken directly from Medicare's Q&A, or the clarification. The communication between providers, so with these 2 additional providers outside of the GP, must be 2-way, preferably oral or verbal, or if not practical, then in writing. So, for example, a lot of practices use fax. So they'll send a fax and they'll get a signature back, signature, tick, yes, you're happy to participate. Now, you should only really claim the item 723, the team care arrangement, once you've had agreement from the other 2 providers. So until you've established that consent from the other 2 providers to be involved, you shouldn't really be claiming the item. The reason why I prefer to gain this consent verbally, because you can usually just pick up the phone, say, look, I've got this patient here with me. Are you happy to take them on? as part of your care. They're being put on a team care arrangement, and I usually then and there either arrange the appointment for the patient and establish whether or not there's going to be any out-of-pocket expenses, or if the practitioner is going to, the allied health professional, for example, if they're going to bulk bill or anything like that. And then what I would do on my end, I don't do any faxing back and forward. On my end, I just document verbal consent obtained via phone on today's date. Now, another thing, Medicare, the communication must include advice on treatment. So again, this is when we're identifying what specific treatment or what specifically is this allied health provider going to be looking after with the patient, not just, oh, they're a dietitian. Yeah. So for example, with a podiatrist, it's not just for podiatry. It might be their patients getting assistance with trimming their toenails, or it might be an assessment, a diabetic foot assessment, or an assessment for peripheral neuropathy. Again, like this, it's the specific thing or focus that care is going to have. Now, there's this concept of blanket agreement, which is not allowed. Blanket agreement is when you contact a provider and say, look, I'm just going to send, say for example, I contact a physio and say, I'm just going to send all my patients your way. Are you happy with that? Yeah, that's fine. And that's where we leave it. That's actually not really allowed. You have to establish contact for each individual patient that you refer, either via, for example, fax or post, or via phone, and documenting that, as I just mentioned. Okay. Again, this is taken from Medicare. The fax form by itself would not meet the requirements if it doesn't include treatment or services to be provided by the other provider. Yeah? So it should have at least that line of what the service is going to be. All right. So when it comes to referral forms, this I actually found quite interesting. When we do our referral forms for the allied health providers, if this referral form contains the name and the practice location of the allied health professional, then the patient can see any allied health professional at that practice. For example, it's Joe Bloggs is the physio at my physio place, and I've listed those two items. Then the patient, if Joe Bloggs isn't available, but I've listed the practice and the practice location, it's my physio place in Hawthorne. Then, if Cindy, the physio, is available, then the patient would be able to use that referral to see the other provider. Now, if the patient referral contains only the name of the allied health professional, but not a practice location, then that referral is a lot more limited in that they must see that the allied health professional that is mentioned on the form. Yeah? So that's why the more information you can put in there, the better, because you're giving the patient more flexibility if you have the destination practice or destination address included. Even more flexibility can be had if the referral form only specifies the type of allied health professional. For example, if it's made out to physiotherapy or if it's made out to podiatry, then the patient can decide which professional they wish to see, which practice or within any practice, which individual health provider. Now, for a bit of a list of who the team members can be for the team care arrangement, here on the left, this is not limited. It's not limited to these providers. There's other providers, but this will give you an idea of allied health professionals that you could refer patients to. So Aboriginal health care workers, audiologists, chiropractors, diabetes or asthma educators, dietitians, exercise physiologists, mental health workers, occupational therapists, osteos, physios. And then at the bottom there I have pharmacists. Very important to note that pharmacists can only really be counted as one of the providers if they're doing something like a home medicine review. If they're just dispensing medication, is not really enough. They're not involved enough, and they're not necessarily yet to be considered a valid provider. Other providers who you may be interested to find out, and I'm not making this up, this is taken from the Department of Health, are services like home and community service providers, Meals on Wheels, personal care workers, probation officers, work cover rehabilitation case manager, and even fitness instructors and personal trainers, as long as they're actively contributing to the plan. So they must be providing feedback into the plan. Obviously, it doesn't mean that by you putting that plan in place that Medicare is going to pay for these services. Medicare only really pays for the services that are on that you'll find on the team care arrangement, the chronic disease management form. But if you're stuck finding second or additional providers for the patient to be eligible, consider these providers, because they can get you out of trouble. Now, I think about specialists. When I say specialists, it's things like cardiologists or endocrinologists. Now, only one specialist or consultant physician can be counted towards the minimum 2 of those providers that I was talking about that need to be part for the patient to be eligible for a team care arrangement. That's in addition to the GP. So you could have an endocrinologist and a dietitian, or you can have a cardiologist and an exercise physiologist. You can have 2 allied health, so you can have a chiro and a dietitian, but you cannot have 2 specialists. So a setup where you have an endocrinologist and a cardiologist and no one else would not be qualified, the patient would not be eligible for that team care arrangement. All right. Now, in terms of referrals and referral validity, the referral is valid for the number of services that you allocate on that referral form. Yeah? Now, this is the interesting bit. Here it says, unused services can be used in the next calendar year. However, and this is a big however, those services will be counted as part of the 5 rebates for that patient of that next year. What does this mean? This means that if you have a patient who, again, we have the example of someone who had their plan put in place in November 2012. They were referred to, for example, say 5 sessions with their podiatrist. They were only able to fit, say, 3 sessions in before the end of that year. That referral, for the podiatrist purposes, the podiatrist still has 2 authorizations, yeah, to provide services up their sleeve on that referral. However, if we clicked over into the new year, when that podiatrist provides those 2 services, those 2 services are now going to be the first 2 of their total of 5 for this patient. So even though they were left over in a referral from last year, now if the patient has those 2 services, they'll only have 3 services left for any other allied health, and that is it for the year. I'm happy to clarify this if there's still questions around it. When all referred services have been used, or if a referral is needed to a different allied health professional, then patients need to obtain a new referral. Now, I often get asked if we need to print out a new referral, does that mean that we need to review the plan? Do we need to put in a 732? And the answer is no. If it's not time for the patient to have a review, or it's not time for the patient to have a new plan, all we do is we would generate a new referral with the new details of either the new allied health provider or the additional services, keeping in mind that Medicare will not, no matter what you do, pay for more than 5 services in total in any given calendar year for any given patient. Okay? So it doesn't matter how many forms we print out, the patient can only have access to 5. Yeah? Yeah. The referral form that should be used is the one by the department, which I'll show you in a little bit, but you can actually use you can refer using whatever referral template you have, as long as it contains all the components of the form from the Department of Health. And this is the form, which a lot of you would be familiar with. This form, if you have it in your practice software, it'll auto-populate a lot of these details. It'll prompt you for who the allied health professional is. And again, if we put the practice address, then it gives the patient freedom to access any provider at that practice. Yeah? And And this is where we would allocate how many services, and this is done in collaboration with the patient. So with the patient, we discuss, look, you have 5 services up until end of December. Which providers, or how do you want to divide the services? They might say, oh, look, I want to have 5 with the podiatrist. So that's fine. We would put 5 there. The GP would sign this, date it, and that's your referral. Always providing a copy of the original plan to the patient and one to the allied health provider, as long as the patient is happy for all that information to be shared with the allied health provider. If the patient wants to censor or modify or withhold some information, for example, you might have a patient who suffers from a mental illness and they don't necessarily want their physio to know about their mental illness, then you can modify the copy that you provide to the allied health, because really the patient should, you need consent from the patient to share their personal and medical information. Okay. Now, in terms of the allied health professionals, their reporting requirements are actually, they should actually be, once you refer to them, they should be providing you with a written report after the first service and the last service. So if you refer them for 3 sessions with a podiatrist, the podiatrist should be providing you a report after the session 1 and then one after session 3. If there's obviously changes along the way, then and that are or something drastic that needs to be reported on, then they should really be reporting more frequently. And some of the things that should be included in those reports are things like any investigation and tests or assessments, what treatment and what the future management is going to be for the patient's condition or problem. Okay, now, actually, before we go any further, I've been receiving a lot of questions here, so let's just try and address some of these. So one question here is, does the 2-year cycle apply to a diabetes care plan? I was under the impression we needed to do a new plan for the PIP cycle of care. Okay, this is with the diabetes cycle of care, this is 2 things. So you've got care plans on one side, and then we have the diabetes cycle of care on the other. The diabetes cycle of care is really done on usually every 12 months, and that's just checking that all the components of best management of a diabetic patient have been done or undertaken over the last year. So what happens is, if we have a brand new patient to the clinic, for example, or a patient who's a diabetic and they haven't really been put on any kind of plan or haven't had a diabetes cycle of care done, then you could do a brand new care plan, so a GP management plan and a team care arrangement today, for example, because that's going to be planning and looking at care that we're going to be delivering in the future. So that's looking forward. We can build that brand new item today. If on the day that they're coming in, if today they're coming in and you've actually provided or they've received all the care that they need to tick all of the components of a cycle of care, which looks back into the past, going, okay, over the past year, have we provided at least one eye check over the last 2 years? Have we provided at least foot check? Think of the top of my head, there's 2 blood pressure checks. You need at least 1 cholesterol and HbA1c check. So if we can tick all those elements and the blood pressure and the weight and all of that, then we can also claim the diabetes cycle of care today. Why? Because it's not double dipping, because the cycle of care is looking at service that we've already provided, so it's looking back, and the care plan is looking at services that we're going to provide. So what would happen then is that we would, in 6 months' time, we would review the care plan, and then in another 6 months' time, now it's time to do a new cycle of care. There is a conflict between the cycle of care and the review of a care plan. Why? Because the review of a care plan is looking back, just like the cycle of care looks back at care that we've provided. The review of a care plan looks back at, have we met these goals? How did we go with the progress? Have we delivered all these services? So Medicare's recommendation in that instance is that the review and the cycle of care should be at least 3 months away from one another. What I would recommend is give priority to the cycle of care and do your cycle of care every 12 months. And if they were due for a care plan review, just postpone the care plan review another 3 months after the cycle of care, or another 6 months. Yeah, hopefully that clarifies that a bit. There was another question about is this session being recorded and will we be able to watch this later? And the answer is yes. The session is being recorded, and I will put the video of this up, and I'll send an email with the link so you guys can access it later on. Can you get an extra 5 allied health provider services up to 6 months, giving 10 per year? The answer is no. Medicare, it doesn't matter how much paperwork you put in place, Medicare will only look at, does this patient have a 721, 723 in place that's triggering or allowing the allied health services? And then if the answer is yes, they'll go, okay, so between January and December, we'll pay for up to 5 of these sessions, keeping in mind that the amount that Medicare pays is set, and that may not cover what the private allied health provider is charging. So there may be out-of-pocket expenses, or the allied health provider may require the patient pay in full and then get their money back from Medicare. So it's important that we let patients know to always check beforehand, because there are patients that even if they can get the money back straight away from Medicare, they just don't have it in their bank account to have that immediate out-of-pocket expense. Now, another question is the 10997 item number, that nurse monitoring and support item, available to bill for an RN only, or can it be billed for practice nurse, an enrolled nurse? The answer is yes, both. So regardless of whether you're a registered nurse or an enrolled nurse, you can claim item 10997. You must be a nurse. So a receptionist wouldn't really be able to use this item. Aboriginal healthcare workers can use this item from memory, but definitely if you're a nurse, make sure that you put in the patient's progress notes, put an entry of what the focus of that session was, because that's what an audit will be looking for, an entry into the progress notes. Question, can we get a copy of this presentation? Yes, if you send me an email, I can send you a copy of the slides. And another question, can a patient have an asthma cycle of care and a GP management plan? Very good question. The asthma cycle of care is controversial when it comes to care plans, because asthma cycle of care, they're both about providing, obviously, services, and Medicare's recommendation or instruction in their Q&A is that if a patient has asthma, and asthma is the only thing that's the condition, that's the only problem in existence, you should either choose to do care plans or use asthma cycle of care. You shouldn't be using both at the same time. If you have a patient who has asthma and diabetes and a whole heap of other conditions, and that's fine, because you could do a care plan around their other conditions, and then an asthma cycle of care to just manage their asthma alone. If asthma is the only thing that's wrong, though, you should choose either between the asthma cycle of care or the care plan. I would always recommend to use care plans, because one, they're a lot more straightforward as item numbers to claim and to keep track of. They also, you have the opportunity of giving the patient access to allied health, which the asthma cycle of care doesn't. And they're actually more, the rebatable fee is higher, so the practice actually gets more money or gets a higher rebate for the care plan than you would for an asthma cycle of care. The other thing is with the asthma cycle of care, and I haven't really done a lot of them because I always prefer to do care plans, but with the asthma cycle of care, it's only really for patients with moderate or severe asthma, whereas you have more flexibility with a care plan. Even if a patient's got mild asthma, they're eligible for a plan. Obviously, as long as you're meeting any other eligibility requirements that you need. But yeah, it's just care plans give you more flexibility. Another question, if the patient has 2 different chronic diseases, can they have 2 care plans and claim 2 team care arrangements? The answer is no. So one care plan and team care arrangement should really encompass all the chronic conditions. So yeah, again, if you have someone that has multiple chronic conditions, really you can't. Medicare won't let you have multiple GP management plans in parallel. One will have to cover the key things. Always keeping in mind, though, that if the document that we put in place for the GP management plan is too overloaded, if it's got too much information, it just goes on for pages and pages, it's not actually a useful document for anyone. It's not useful for the patient, it's not useful for us, and it's not useful to any other providers who have a look at it. So always try, and this is certainly what I do in practice, choose the focus of your plan. For example, I always list all the conditions and all the issues and problems, but then I'll focus the goals and patient actions and interventions on what are the main 3 or 4 issues, with the view to, well, as we review things and we're getting on top of some of these issues, then we'll start addressing some of the other issues, some of the other problems, and look at creating more goals. But don't try to solve all problems and put all goals into the one plan if the patient is quite complex. What else? If the GP is meant to communicate with the allied health professional directly to report verbal consent in care of a patient, how can the patient be referred to just a type of allied health professional or the practice name and practice location of the allied health provider? Not quite sure I understand this question. Let me just have a look. So if the GP should be communicating with the allied health professional, oh yeah, I see what you mean. So the question is, if the GP needs to be communicating and getting verbal consent from the allied health professional or the destination practice, how could that referral then be open or flexible, where if the patient decides to see a different physio, for example, at that same clinic, obviously that other provider we wouldn't, would not be the one that we have spoken to. Now, in that instance, you can actually get agreement from, like, on behalf of the practice. So you could either talk to one provider or say, often happens with community health, you might be talking to intake workers, and then it's the practice or for example, say the physio clinic who's accepting the care to look after, accepting the care of this patient and providing input as to what their possible direction of care is going to be. For example, it's going to be around, say, with a dietitian, it's going to be around weight management, or it's going to be around diabetic diet. Yeah, because again, remember, it's a very basic input at this stage. They haven't seen the patient, so they can't give you a comprehensive management strategy. It's just very, very basic. Okay. Another question: what is the nurse's role in the process of a GP management plan or team care arrangement? Well, the nurse's role is we can help with identifying patients who are eligible. For example, we can assist with doing a screening of the database and printing out lists for them, the GP, to decide, yep, let's invite these patients, or no, these patients are not appropriate. We can also do, we can essentially do the bulk of the consultation when we're doing a lot of the measurements and agreeing with the patient on what the goals and treatment and patient actions are going to be, documenting all of that, coordinating services, so we can actually make those phone calls and gain consent from other providers to participate. And then it still needs to be finalized by the GP. So it's not a nurse item. The GP still has to finalize that plan by having a consult with the patient. And obviously any referrals that are going to be issued need to be signed by the GP. Another question, can the item 10997, the nurse monitoring and support item, be claimed if a patient has a mental health care plan? The answer is no. Actually, the patient must have it must be either a GP management plan or a team care arrangement. The mental health care item is, the mental health care plans are separate, and obviously they trigger access to mental health, to psychology services and counseling, which are again separate. But no, you wouldn't be able to claim the 10997. It would just get rejected if Medicare doesn't see that there's at least a 721 number in place. Another question. Hi Magali, when a new patient comes to the clinic and we discover that a GP management plan has already been claimed recently and we're not able to get a copy of that plan, how can I review? And where do we stand from an auditor's point of view? Very good question, very tricky situation. It happens more often than we like it to. If a patient comes to you and they've only had a plan very recently, remembering the GP management plans and team care arrangements must only be done or put in place by the GP or practice that is going to be the usual GP for this patient, meaning this is going to be the practice is going to provide the majority of the services over the next 12 months or who has been providing the majority of the services over the previous 12 months. If it's a new patient, but they're saying, yep, no, you're going to be my new GP, and this is where I'm going to come to, then that's fine. You can take over the care plans from another practice. If there was no paperwork put in place by another practice, what I've done in the past is, and you can't claim a brand new plan unless there's been changes in circumstances. There are exceptional circumstances where you can then create a new plan, but again, that would be if there's been drastic changes to the patient's health or the patient's situation. Aside from that, if they've just moved GPs because they just moved to an area that's closer to you, unfortunately, there's not much that we could do. We could wait for a review time. So we could actually, what I've often done is I'll put together the paperwork from scratch because there may not be even when I've called a practice, sometimes they don't actually have paperwork to give. So I'd put it in place from scratch, and but I wouldn't claim a brand new 721, 723. I would then claim if it's time for a review, then I'll claim a review, and then we'll take over the reviews from now on. If not, there is also an item which is there's 729 and 731. So I don't really want to talk too much about them because they can confuse more than clarify things. And that's when the GP is contributing to a different plan. But that really applies more when, say, a plan has been put in place somewhere else and it's going to stay somewhere else. So the patient has a different GP, or for example, the plan was put in place in a nursing home, and the GP is just providing input, say at the moment of the patient being discharged from hospital or something like that. So there are those items, but again, I wouldn't really recommend delving too much into those ones. From an auditing point of view, you're only responsible for the items that you claim. So if I claim a review, they're going to want to see that I've actually undertaken a review with, it should really be based on paperwork that was available from the original plan. If there was no paperwork available, just document that. No paperwork available, we're taking over reviews, so we created one from scratch, obviously with the patient and their agreement and collaboration. And yes, that's true. Patients oftentimes have no idea that a plan has been put in place. The only way to make sure that the patient is eligible from Medicare's point of view, and by that I mean that a plan hasn't been put in place recently, is to check with Medicare. So you can either ring the Medicare provider line of 132150 with your GP's provider number, name and address, and then you can check up to 7 patients per phone call. They can only tell you whether or not the patient is eligible today, yes or no. But then that means that, that way you find out if you're going to be doing all this work and then not be able to claim an item, or if they're actually eligible. And I have another question. What about different GPs in the same practice? Is it okay from an auditing point of view and plans being reviewed? Yes, multiple GPs in the same practice can review a plan that was put in place by another GP in the same practice. Just be careful, because I've had this scenario in the past of GPs within the one practice fighting because one GP put a plan in place and the other GP felt that they were actually the usual GP that this patient saw. So I've actually had instances in practice where the GPs in the same practice are fighting over who gets to claim the item number. So just be careful, but yeah, it's more than allowed to have GPs, multiple GPs in the practice reviewing the plan for one another. And one other question, if someone has had 5 sessions allocated, how can you then review team care arrangement at 6 months? I'm not quite sure I understand this question. Just wondering if Amanda, Amanda, are you on the line? Because you asked this question. You should be able to. Can you talk?
Oh, hello.
Hello. Hi, Amanda. Yes. So I had that question there from you. If someone has had 5 sessions allocated, how can you then review a team care arrangement? I'm not quite sure I understand the question. What do you mean by that one?
Well, when you review a team care arrangement at 6 months.
Yeah.
Yeah. What do you actually do in that review? Because if somebody's been allocated, say, there's 2 diabetes educator and 2 podiatrists in the original care plan, when you're reviewing the team care arrangement, how can you review it as anything changed or?
Yep. So at the time of reviewing the team care arrangement, so at the time of reviewing the team care arrangement, what you would do is you would check. You don't have to establish contact with the providers again. You would be checking with the patient. Are they seeing? Have you seen the providers that we decided, or do you have appointments? Because they may not have gotten to them yet. That's okay. Or did you need to change them? Did you not like them? Have you decided that even though we had referred you to 3 podiatry sessions, you're only going to need 2, and you actually want to use that extra session for another service? So that's what you're actually reviewing. You're reviewing, and it's also an opportunity to check if the patients have had sessions already. Have we received any feedback from these providers? So this would be an opportunity to contact the providers, and if we haven't received anything, go, hey, what's going on? Can we get some information as to what management is happening? Yeah. Does that clarify things a bit?
Some of the GPs are just reprinting off the team care arrangement without actually discussing it with the patients. And that was how they could justify reviewing it. But I understand what you mean now, and I'll just pass that on as well.
Yeah. So it doesn't. You don't have to establish contact with the other providers if things are trucking along fine. You are chatting with the patient to check, are they seeing the providers? If they have seen the providers, then and we haven't received correspondence, then we need to chase them up and see what's happening. All right.
Do you have to document team care arrangement?
Do you have to what? Sorry.
Document it as part of the team care arrangement review.
Yeah, so when you're doing a review, as I said, you would open your original plan, which oftentimes will be the same document, and just update. And so under the role or input, I would put the dates and say, yep, either continuing to see this provider or decided to change and modify it. But you don't have to create a brand new document. You can just modify the original one and set up a new date of review.
Lovely. Okay, thank you very much. Thank you.
Pleasure. No worries. Now, someone had their hand raised. Diane, give me 1 second and I'll unmute you. Hello, Diane. How are you?
Hi, how are you? Good, Magali.
Good.
I'm just wondering, with the GP management plan, as you were saying, for example, if they had 3 physio and then 2 dietitian, and then decided that they wanted to go to 4 physio and only 1 dietitian, do you need to then go back in and change that management plan to actually reflect that they're seeing 4 by 1? And in doing that, can the nurse go through and do that and then claim that as a 10097 because she's had input with the patient?
Yep.
And would you need to then do that as a review or just as a claim?
No, you wouldn't do it as a review. Yes,
okay.
Because you would only do it as a review if it's time for a review. So if it's been 6 months, or if we're reviewing this patient 3 monthly. But if it's not time for a review, you wouldn't do a review. You would do a 10997, definitely, because you're updating the documentation, you're having a chat with the patient, and you're helping arrange services. But the actual care plan document doesn't need to reflect the allocation of services, because the care plan document only really says what providers are involved. Yeah. So the care plan document will say podiatry and dietitian, for example, but you don't actually have to say 4 podiatry or 2. We put that allocation on the referral form. Yeah?
Right.
So it's only the referral form. So if the patient decides that even though we sent off the podiatrist a form that had 5 sessions authorized to them, but now the patients come back going, look, I've seen them twice and I think I've had enough of that. I would like to use my next 3 with a physio. Yeah, then that's fine. We explain to the patient that we'll print out a new referral form for the physio and allocating 3, and we explain to the patient that as soon as they start having, like as soon as they have 5, doesn't matter who they have them with, anything else will be rejected. Yeah?
Yes.
So even though we had authorized the podiatrist for additional ones, if they decide to go back to the podiatrist, but they had the additional ones with the physio, that they're not going to get money for that. Or yeah, exactly.
Okay, but we still need to actually just make allowances and send that referral form, for example, off to the physio saying they now want to come and see you 3 times rather than 2.
Yes. So because the thing is, the physio needs authorization. They only have authorization for the number of sessions that you put on the referral. So if you only authorize them for 2 sessions, and all of a sudden the patient goes, look, I love them, I want to see them for all my 5 sessions, then you should give them another referral for the additional 3, because otherwise they won't be able to provide them. Look, a lot of them do, because they don't realize their audit requirements on their end, like the allied health requirements on their end. But this way you know that they should really be they should only be providing services for the ones they have authorized.
And it should definitely, you can't do all 5 though with the 1, can you? It's just 4 and then 1 at the most, because they've got to be.
No, you
can. I thought, but because they had to see the 2 healthcare, you could have 5. So
so you can have 5 allocated to the 1 provider. However, you need to have 2 providers on the plan. So what that means is the other provider, if the other provider is a specialist, then no issue, because they weren't going to be getting any. But if the other provider is a dietitian, then they have to know that the other provider is going to be private or maybe under community health. So if the other provider, some community health centers are happy to take on patients under team care arrangements, but look after them under their community health funding, so it's not using up the patient's allied health.
So they could, for example, do 5 with a physio and then have 1 Meals on Wheels, for example, and that would then cover that double. Yes.
Definitely.
Okay. Yeah. Okay. Thank you.
All right. Pleasure. All right. So there's still a couple of questions here. Before I keep going, just for those of you that, because we're already a bit over, I'm happy to stay and answer any of the questions, but I just want to wrap up the main thing. Make sure that you check out the care plan resources at practicenursing.info. Again, it's on the resources care plan. And then we also just wanted to make sure that, we've got a couple of intensive workshops coming up. We have one called Best Practice in Travel Medicine and Related Vaccines, which is happening in the morning it's a 3-hour intensive workshop from 9 a.m. to 12 p.m. And then in the afternoon, we're doing a workshop on mastering the top 3 health assessments in general practice. So that session is going to include over 75 health assessment, the 45 to 49 health check, and the 4-year-old healthy kids check. The 2 dates, so that's, if you come to both, that's a jam-packed day of info. The 2 dates are going to be for Melbourne. It's going to be Saturday, the 1st of June, and for Sydney, it's the 15th of June. So if you're interested, just go to the site, practicenursing.info, and under education, you'll see the 2 workshops, and you can register there. If you have any other questions, always remember that you can use the contact us form on the website and ask any questions that you need, and I can get back to you via email or give you a ring. So that's the conclusion of the main content. I will keep addressing questions until they've all been answered. So feel free to stay on the line. If you need to go, then you may go. Thank you for your time. And yes, all right. So let me just address one more. There's another question here. Can I claim a 10997 without having contact with the patient? Very good question. For example, if I receive the report from podiatry for a diabetic foot check and I enter it into the notes in the diabetic review session, also bring the relevant information to the doctor's attention. Okay, in that instance, no, we need to have some kind of patient interaction because it's a support and monitoring with the patient, so it should really have a component of liaising with the patient. The question that we had in the past is, can we use phone calls? Can a phone call be enough? And we actually did receive some correspondence from Medicare saying that in writing, which is quite handy because it binds them when they send it in writing, as long as the GP is happy that you're competent enough to handle the whatever whatever needs this patient has in terms of their care over the phone, and that's going to be resolved adequately, then that's fine. So it can be claimed for a phone consult. Again, as long as it's addressing some of the issues, or at least one of the issues that's mentioned in the management plan. Okay. Now, another question here. What constitutes a new GP management plan at 2 years? Just the date, or does the change in condition prompt it? So the reason why we would do a brand new plan is if we get to a point where we've reviewed this plan so many times that really we're running out of space, and there's so many changes that we really just need to create a brand new one, because it's been too long since we've done a full assessment, or a full it's essentially a full assessment of this patient's condition. So that's why usually after 2 years of reviewing the same document, it's usually a good time to go, okay, so let's just start from scratch. Let's do a plan from the beginning instead of just, tweaking and changing the document that we've been working with. But sometimes you may find that you don't really actually need, you might get to the 2-year mark, and you might find that actually I can keep reviewing this every 6 months until a new plan is needed. Now, I just had Silvana, you had your hand raised. I'm just going to unmute you. Silvana, are you there?
Yeah, I've just sent you the question.
Hi, Silvana. How are you?
Hi, good,
yes.
Thanks. I've just sent you so the question is, can you use pathology as a part of the team care arrangements?
That's a tricky one. So with pathology, I know of GPs that have gotten away with using pathology. I personally have never used them because, you don't really get input into the plan.
What if they're getting INR testing and dosing?
Possibly, possibly in that instance, if you're having a more consistent relationship with the pathology, with the lab, not just the lab, but with the actual provider of the pathology company, it's a maybe. I'm not 100% on that one. I personally haven't really been using them, but I do know of some GPs that have and have been okay with that. And I know that there were several questions that you had sent through before that that I'll address. Now, you also had a question around home medicine review. Do you need to complete a separate home medicine review referral? Is that right?
Yes.
If you're including a pharmacist in the care plan and the team care arrangement. So if you're including a pharmacist, then yes. So if you're including a pharmacist because they're involved as part of a home medicine review, and that you haven't actually initiated one already, then you would. The way that you do that is a lot of for example, Medical Director and a lot of the clinical softwares already have the template built in, so you can just do the home medicine review template, and it's essentially just a referral. That referral includes information like obviously all the patient contact details. The patient has to agree to have this review done and to be contacted obviously by the pharmacist. And it'll have information obviously on their current conditions and their current list of medications, the reason for those medications, and if they're taking, if there's any issues with language, if for example if English isn't their first language and the pharmacist is going to struggle to communicate with them. Also if they have any devices, or if they're using Webster packs, or if they're using those set boxes or anything like that. So
could you not include that information in the care plan?
Yeah, you could, but I mean, as I said, like the actual referral template for the home medicine review auto-populates a lot of the information. It certainly auto-populates all of the patient information, so you wouldn't really need to do much more from that, other than selecting if there's any issues with language or if there's any additional notes that you need to give them. But yeah, under them, if you're using Medical Director, I'm not quite sure with ZMed because I haven't seen the templates that come supplied with ZMed. But yeah, definitely Medical Director. My guess would also be with best practice. you'd have under the supply templates the home medicine review one, and it's really, really easy. So what happens is you'd send a referral, the pharmacist would then get in touch with the patient. They would do either a home visit where they would look at the medication, or the patient can decide to take the medications into the pharmacy if they don't want a home visit. And then the pharmacist will send the GP a report on their findings, and then the item can't actually be claimed until the GP has a look at that report and puts a plan of action in place, which may be, look, there's no changes needed, or actually we need to cancel some of these or reduce the dose or shift medication, and that should really happen with the patient. That's when the item can be claimed for the home medicine review. But we can initiate that by sending the referral and getting the pharmacy to agree to do that, and that would be enough to make them part of the team care arrangement. And then you had also questions around the 729 items and the 731, which again they're a bit more they're trickier, and they're more rare, and they're more around the GP providing input to a plan that's been done by someone else. And that's when we're not ever going to take over that plan. For example, a patient who's a resident of a residential aged care facility, and they already have a plan that's been put in place by the facility, and the GP is just providing input. So that item 731 then would give the GP a rebate for their time and energy into providing input to that plan, and it also triggers the residential aged care patients' access to allied health services. There was another question of, can we claim an item 23 or a standard consult at the same time that we do a care plan, or at the same time that we do a review? And at the moment, yes, we can, as long as we've had a different, if they're coming in on the day and they're having the care plan, but they're also coming in, they happen to have a chest infection, or they've got an infected toenail or something that's completely unrelated to their asthma care plan. You can claim an item 23. That will be changing. That's one of the things that changed in the budget now. So from next year, we will not be able to claim a standard consult at the same time. When you do that at the same time, you have to annotate that it was for an unrelated issue. Otherwise, it'll get rejected.
Okay.
What else? Did you have any other questions? Because there was examples of team care arrangement review. What did you mean by that? To provide an example of a team care arrangement review. I think
you pretty much answered that. Just maybe, you know.
Okay. Yeah.
Yeah.
Yeah. Good. Did you have any other questions? Or?
No, that's it.
That's it. Awesome. Thanks for that. Thanks for participating. Now, if anyone has any other questions, make sure you can either raise your hand and I can unmute you and we can have a chat, or send the questions through. Otherwise, we might just bring this to a close. Thank you very much to everyone for participating. And look, we've only just scratched the surface with this. It's massive. Care plans and chronic disease management are a massive, massive topic. Might look at doing a part 2 to this, where we can address even more questions, or if you go back into your practice and you start implementing some things and then you find that, oh, I'm not quite sure about this or that, yeah, we'll do, we could possibly do a second session. So if there's no other questions, I just want to say thank you, and I look forward to either chatting to you in the future or seeing you at a workshop. Have a lovely night, and I will see you later. Bye.